There I am. Hi, everybody. Welcome to Cosi. A couple of minutes to jump on board this evening. For those watching the replay, thank you for watching, and thank you guys for these past few weeks. Y'all have been amazing about giving me shout outs in the comment section. So if you are watching the replay, please hit replay in the comment section. I do like to go back and pick up any questions that I may have missed during the live show, or any questions coming in during the replay time as well. So we got the first one coming on board. Hola, compadre, ¿cómo estamos? Thank you for being here with us this evening. All right, guys, don't be shy. I know I'm a few minutes late this evening. I'm already getting messages from you guys as to where are you? Where are you? I'm late and I do apologize. All right, we got Harsh on board. Hey there, Harsh. And who else we got? We got Susan. Thank you for coming, Susan. Guys, let me know who you are and where you're from and what's in your drink. Brian, do you have your Bustelo this evening? I didn't bring a drink because I was running late this evening. Hey, Chuck, watching me from the YouTube channel. So, guys, I do broadcast to both my Facebook Cosi Talks and my YouTube Cosi Talks page. Two reasons. Number one, it's a shameless plug for my YouTube channel. I've been putting some more goodies up there. And if you guys haven't already done so, go to my YouTube channel, hit subscribe. And also because I know several people have some trouble sometimes finding me on Facebook, and they find YouTube just a little bit easier to use. We've got David coming on board from Newberry, South Carolina with his green tea. What's going on, Damon, man? And there's Felicia. There's my girl, Felicia. Thanks for coming on board. We got Timothy. We got my Tar Heel Denise from North Carolina. And Brian did bring his Bustelo. Good. One of us needs to be drinking Bustelo. Andrea, yes, thank you. And I just got your message now, Andrea. You weren't the only one who was asking me where I was. Long story short, I was on mom duty. My girls had a swim team meet with their school. So that's, just one of the enjoyable things about being a parent and watching your kids at the swim meet. So I came in scurrying at the last minute, and here I am. All right. Hey, Van Gregory. Howdy from Texas. Aw, don't mess with Texas, man. We got Paula on board. Susan is on drinking her Coke, switching to water. We got Pastor David. We got Eric. We got a nice crew on board here, guys. Thanks for joining on board. We got Tom. Let's see. How many of you guys were here last week for my talk with Dr. Roubeau? She was the plastic surgeon from MD Anderson. Fantastic human being. So she was on board last week, and she works with osteosarcoma. That is her niche specialty. She is even more of a unicorn than I am. So she is a plastic surgeon who performs targeted muscle reinnervation on her oncology patients. And there was just so much wonderful information, first of all, just on osteosarcoma. And even though we don't have less than 2% of amputations are cancer related, we do have a very high concentration of cancer survivors on the show. So that show is for you guys. But even for those of you who have amputations related to peripheral vascular disease or trauma, there was a lot of good information on that show about targeted muscle reinnervation and how it can help with neuromas and phantom pain related to neuromas. So highly encourage you, if you didn't watch last week's show, to go and check it out. It's on the YouTube channel archives. What's up, Johnny V from Poughkeepsie and the Cosi Talks house? Hey there, Bonnie. Got her coffee. Got your power knees. Ooh, Bonnie, I want to hear about the power knees. So guys, Össur has, it's called a power knee, and it's different from the typical microprocessor knee. I have yet to see one in person. I've heard a lot about it. I've talked to some people from Össur about it. I'm excited, and I really want to see one in person. So guys, those of you who have an Össur power knee, I would love to hear your thoughts on it. That's how this is how I do my fact finding. I look at the research, I talk to clinicians, but I love hearing the feedback from people using these feet and knees and products that I haven't seen just yet. So love to hear from you. Why am I late, Kristen? I'm late because I was being a mama this evening. I was out the swim meet cheering my girls on for a little while, and then we got thundered and lightninged out. So there you go, Florida. All right. Thanks, Mark S. You guys give me a hard time. All right. Teresa's on board. Oh my gosh. You guys are awesome. Hey, Steven. Oh, Jacksonville in the house. All right. Thank you, Bonnie. I would appreciate that. So guys, for those of you who are watching me for the first time this evening, wondering who this crazy frenetic woman is on the show, my name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for, it's going to be 20 years in December, guys. 20 years years of being a licensed physical therapist. That's a long time. The thing I can't think of is if I've been a therapist for 20 years, that means I must have gotten my license when I was 6 years old. Anybody falling for that one? No? All right. It was worth a try. All right, guys. So I'm happy. I'm really, really happy because y'all sent a lot of questions this week. And I love it when you send me questions. So I'm going to type in here my email. Okay, so for those of you who are new to the show, or those of you who are some of my oldies watching the show, that's my email. I read every single one of my emails and I answer every single one, even if it's just a short, quick reply. But this is where I get all my questions. This is a lot of times where I can get my questions. So if you have any questions, guys, send it to me right there. Yeah, Diana, me too. I hope I'm not getting kicked off either, but it's kind of thundering and lightning around here as well. Oh, thank you, Teresa. She bought it. She bought it. We're good. All right. So this first question is coming in from Kim. Kim asks me, I recently had the TMR procedure, targeted muscle reinnervation, done after being a right below the knee for 3 years. My surgeon connected the cutoff nerves to other nerves, wrapped them instead of putting them into the muscle. Have you heard it done this way? I'm still having lots of phantom pain, but I know it takes time and I'm crossing my fingers. So guys, just a quick recap, right? Targeted muscle reinnervation. What is it and why do we care, right? So when a surgeon does a traditional amputation, they cut through all the soft tissues. They try to get rid of anything that's necrotic, the dead tissue, infection, whatever's going on. And then they'll cut the nerve. Okay. And typically they cut the nerve and the nerve retracts back into the soft tissue. And that's kind of where it stays. The problem is it starts to form scar tissue. It starts to form what's called an neuroma. And if it's a sensory nerve, right, then that neuroma is going to start hurting a lot. It can be in the form of pain in the residual limb. It can present as phantom pain. Okay. So a lot of this, let's see, I'm trying to think. The statistics are there's approximately 2 million amputees living in the United States, and approximately 25%. Okay. So it's 500,000 people living in the United States have phantom pain related to neuromas. That's a lot of people, right? So what they have discovered is a procedure called targeted muscle reinnervation where they get that nerve and instead of just letting it retract into the soft tissue, they plug it back into a specific point in the muscle. Okay. They pair it up with actually another little nerve. I love how Dr. Ribot described it last week as the buddy system. They take the nerve and they kind of connect it to another nerve that's already in the muscle. So you're kind of completing a circuit there. You're making the nerve happy. You're giving it something to do. Right. And the outcomes that they're having with relief from phantom limb pain caused by these neuromas is very, very promising. Okay. So what Kim had, what I think she's describing here is what's called RPNI, regenerative peripheral nerve interface. And it's kind of like a sister procedure to TMR. Okay. So instead of the nerve going back into the big juicy muscle belly, what the surgeon will do is they'll take a little bit of muscle graft. So they'll take a little bit of a slip of muscle and they'll wrap it around the nerve itself. Okay. So it's very similar in that we are trying to get that nerve back into muscle, giving it something to do, but just the technique and the strategy is a little bit different. And if you guys will remember, I had a wonderful surgeon by the name of Dr. Dedesi on the show about a year ago. Okay. He's an orthopedic surgeon and he does both procedures. He does TMR and he does RPNI. And I asked him and I go, well, what makes you choose one over the other? Right. And he said, basically he looks at the field. So he looks at what's available in him in the anatomy of the person in front of him and just decides, okay, what's going to be a more appropriate procedure. Okay. And oftentimes you see the RPNI a little bit more often also in the hand surgeries, right? So when they have a neuroma somewhere in the hand or in the residual limb of an upper extremity amputee, they will use the RPNI. So let me just write that down. RPNI, can't type today. Peripheral nerve interface. It's a mouthful. I'm not going to lie. Okay. So you can just kind of think of RPNI and TMR kind of like sister surgeries. They're accomplishing the same goal in trying to get the neuroma taken care of and plugging in that nerve into muscle tissue so that it's happy. Make sense? All right, let's see who else is in here. Let's see. Yes, Tom, parenting will always definitely come first, especially when you have 4 kids. It always comes first. There we go, right? And I love it. All right, let's see. Oh, Steven says, I thought you thought I was 24. Steven, you are now my new best friend. Thank you very much. We got Sandra in from Gainesville, Florida. Oh, thanks, guys. Questions into the section. Yes? All right. And this one was just a comment that made me smile. Liz sent me a comment. She says, I always get really psyched to work out after your shows. And that just makes me smile. So thank you so much for sending me that comment. I think she sent me that comment after there was one show that I was talking a lot about the Cosi Talk Strong Body program, the fitness program that I have online. So really appreciate that. Thank you, Liz. Let's see. Okay. So Nan sent me this one, and Nan says, do you have any videos for someone who is above the knee and right above elbow? Learning to walk with no arm and leg on the same side seems impossible to balance, especially for a big man over 6 feet. And yes, you're absolutely right, Nan. A lot of people they really underestimate just how much we use our arms for balance and for coordination during gait, and especially so during higher level activities such as running. And I had a person ask me once, and they were just like, if you had to choose between being an upper extremity amputee and a lower extremity amputee, which one would you choose? Which one do you think? And I go, well, it's a tough question, but I think for me, I find it more challenging to be an upper extremity amputee, for obvious reasons that we use our hands the way we do, but also when it comes to gross motor function, right? Not having that arm there can really affect your balance and affect a lot of things more so than people realize. That being said, it doesn't mean it's impossible to learn, okay? And how I would approach treating someone who has an above the knee amputation on one side and an arm amputation on the same side is very similar. We start with those basic weight shifting exercises, and I'm really excited. I'll be speaking at a conference in November, talking about some of these foundational exercises and the importance of how to get everyone in on these foundational exercises. So what are the foundational exercises? The ones that I give to basically every single patient that comes into my clinic, every patient I've ever laid hands on, pretty much. Weight shifting, huge, and probably the most underestimated exercise in physical therapy world, in my opinion, right? Weight shifting, and in a particular order: weight shifting side to side, weight shifting forward, backward, anterior, posterior, weight shifting in diagonal directions, right? And then there's many ways that we can build upon the weight shifting exercises to make it more challenging, right? So this is always one of my favorite exercises to throw at people and really show them how much it can really, really help, okay? The other one is doing progressing, especially with my above the knees, working with the prosthesis in stance, okay? So guys, when you are walking, right, you guys some of you may have heard the gait cycle talk. How many of you guys remember the gait cycle talk? Do y'all remember that? Show of hands in the comment section. Do y'all remember when I did the gait cycle talk for my live event series? And is this a shameless plug? Absolutely. So on my YouTube channel, you'll see a little section called live event series. And in it, you'll see a gait cycle, talk on the gait cycle. Eric remembers. Hey, Steven. So in the gait cycle, guys, there's 2 parts. There's the part where your leg is on the ground, called stance. And then there's the part where your leg is swinging through the air, called swing phase, right? So when it comes to working, especially with my above the knee amputees, I really try to emphasize that stance phase first, meaning the part where your foot is planted on the ground, right? A lot of stuff happening there. Your prosthesis has to learn to accept the weight of your body. Your muscles have to activate to provide that support and stability, right? And then preparing you to propel you forward, right? So a lot going on there. So I'll try a lot of those movements there first. And that's part of my foundational exercises. You remember? Okay, you guys remember? Good. Hey there, Ms. Debbie. Let's see. She says, I'm tardy. My daughter, 31, is congenital bilateral below the knee, and she did a magazine ad for Oh Sir Wonderful, and she got a free pair of running blades and Nike clothes. Score. Yeah. So Miss Debbie, please, please, please tag me when those pictures come out, because I would love to see those pictures. How cool is that? What kind of running blade did she get? Did she get the Flex? Tell me about it. All right, let's see. Oh, Susan. Oh, girl, you just touched upon one of my favorite subjects, and we need to talk about this. Susan says, I need to know about the pelvic floor and why it's so important, and how do I know if I have to work on it? Yes, that is what it's called, Susan. You are absolutely right. And this is something that I don't address enough on the show. Okay. So just a quick recap on anatomy, and I can't use Bob because Bob, we're not going to be able to see his pelvic floor. Okay. So the pelvic floor, both for men and women, is the area of your body that meets the saddle. So if you just pretend that you're sitting on a horse on a saddle, it's the area of your body that is touching the saddle. That is what's considered to be your pelvic floor. Okay. And it's made up of muscles. And guys, let me just put the disclaimer out there. I am not a pelvic floor specialist. Okay. I have colleagues, physical therapists, who are brilliant. And in my opinion, they're brilliant clinicians, and they are pelvic floor specialists. And this is something that if you need treatment for pelvic floor, you need to find a specialist. And thankfully, there's a lot more of them out there than there were just even 10 years ago. Okay. And this applies for both men and women. Women typically will have more issues with their pelvic floor, right? But men as well. Okay. So what happens is the pelvic floor is made up of muscles, and think of it like a hammock, right? So since there's no bones supporting that hammock, right, over the course of time, that hammock can get stretched out and those muscles can get weak, right? And both men and women can start having symptoms like urinary incontinence or leaking, as it's called. And again, this is something that a lot of times people have a hard time discussing with their clinicians, have a hard time bringing it up, or they think that this is just something that's normal, that happens with old age, or that happens with pregnancies or with women after having children. But it's not. We're discovering that many of these issues related to the pelvic floor can be rehabilitated, can be, I hate using the word cured, but can be fixed and taken care of. Okay. So why does this matter for those of you who are amputees? Well, first of all, if you're female, okay, you're going to be more prone to having injuries of pelvic floor. Okay. So again, some of the things to think about, I know, and David, it's a ticklish subject. I'm not going to lie. It's a ticklish subject. And to talk about it on live talk show like this, like, yeah, I feel like I should have a margarita or something. Anyways, some of the symptoms, like I mentioned, urinary incontinence, bowel incontinence, problems with using the bathroom, going number 2, right? Constipation, pain during intercourse. Okay. Symptoms such as just discomfort in that area. And guys, I'm just touching upon some of the symptoms. There's so many more. Okay. But again, this is where having conversations with your OBGYN, having conversations with your physical therapist. Okay. I'm not a specialist, but I can certainly screen my patient to see if they need a pelvic floor specialist. And I have referred some of my patients to pelvic floor PT. Okay. So what happens? So if you have a pelvic floor that is compromised in some way, let's say there's weakness in the pelvic floor, right? And you put on a prosthesis and you start working hard, right? You're working harder. You have to expend more energy to using the prosthesis. Your pelvic floor is considered to be part of your core. Do y'all remember that? Okay. So if you're putting all this effort into it and the bottom, your pelvic floor is not strong enough, then it's going to carry a lot of the stress and it's going to weak and make those symptoms possibly greater. Okay. So this part we can use Bob for demonstration. So with your human core, right? It's not just the abdominal muscles in the front. Oh, crikey, guys. I forgot to plug in my computer. Give me one moment. I am so sorry. That was careless of me. I was in such a hurry to get the show going that I forgot to plug it in. So just a moment, please. This is what we call mom brain, big time mom brain. So excuse me. Okay, sorry about that. Okay, so with the core, guys, we're talking about the front abdominal muscles, the back muscles, the diaphragm, the pelvic floor at the bottom. Any one of those structures is weak, okay, you're going to have problems with your core. You're going to have problems in your stability with walking. And those of you who are having pelvic floor symptoms, it's going to aggravate those symptoms, right? Because you're doing a lot of effort. So you're doing what's also called a Valsalva maneuver, where sometimes if you hold your breath while you're doing a hard activity, right, and you're increasing all the pressures inside, and that's stressing out your pelvic floor. And then, gentlemen, you remember how I told you you guys are not exempt from this? Again, with the aging process, some gentlemen who have problems with enlarged prostates, right, it's going to start to cause problems with the pelvic floor. And again, this is where my knowledge starts to run out. But again, this is something that if you're experiencing some of these symptoms, it's worth talking to your clinician. Now, I will give you this warning. There are some clinicians out there that are not aware of the specialists for pelvic floor. I know that some of the OBGYNs I've spoken to, they don't know about this, and it's very sad. They're starting to become more aware, but they don't know about this. And for you gentlemen, your internal medicine or your family practice doctor may not be aware that this exists, but it's as easy, guys, as going to Google and putting in there pelvic floor physical therapist in my area. Thankfully, now we have so many specialists coming out in this field that you can find one on your own. Okay. So here, let me. Oh, thank you, Miss Debbie, for sending that. I appreciate that. Yes. So Brian says, hang on. Sorry, I'm trying to catch up with your comments. Brian says, I've seen so many questions with people unaware of the total effect of gait training. It's really true, guys. It really is a head to toe. That's why my profession exists right now, is because it really is a head to toe effort. Let's see. So Susan asks, so do I go to my PT to talk about the pelvic floor first? I would start there, Susan. You can either, if you have a good relationship with your OBGYN doctor and he or she has, an awareness of pelvic floor physical therapy, you can start with your OBGYN and they can write you a prescription for it the same way that any doctor would write a prescription for physical therapy. If you have a good relationship with your PT, then yes, by all means. Like by now, every PT should know of another PT that practices pelvic floor therapy. Like there's enough specialists out there that even if your PT does not have a lot of knowledge about it, they're going to know someone who does in your area. And like I said, worst case scenario, Susan, you can Google it and you will find people. I've done that several times actually for friends across the United States where I just Google in their area and I can say, yep, this one's a pelvic floor PT and go see them, right? And again, guys, pelvic floor PTs, they really have to do their homework to specialize in this field. This is not something that is covered extensively in our during our graduate school studies. So along with that means that the person who is going into pelvic floor PT, they're going to be very good at what they do and they're going to be very dedicated. So little plug there for those in my profession. Yeah. Let's see. Yeah. So David says, I'm a guy, and after being down in a hospital from COVID, I would get Charlie horse and cramps in my taint and during physical therapy to get back on my feet. And again, David, for me, I am not as familiar, especially with the male version of pelvic floor therapy. So, but there's just certain signs and symptoms. And when I hear my patients talking about or asking me about this, is it normal for me to be leaking while I'm wearing my my prosthesis? My male patients, they're a little more shy, obviously. I'm female, so they're a little more shy about talking about some of these symptoms. Okay, so that's the beauty of this show, is I'm letting you know about it now, and where, if you are having some of these symptoms, that you can go and find some help for it. So Susan says, I had abdominal compartment syndrome and have no muscle there. Will that be a problem? So yes and no, Susan, depending on which muscles. If there were muscles removed, if it was just the rectus abdominis, meaning the six-pack muscle, then you've got a lot to work with. Okay. It's the deeper muscle, actually, the transverse abdominis muscle, the deepest muscle within your core. That's actually the most important one there. Okay. So, and I've had patients in the past who were breast cancer patients, and they took out the rectus abdominis to use it for their reconstruction. So, and those women were able to function well. Actually, the outcome studies were not too bad. So yes, Susan, there's always something that can be done. So Susan says, we don't get OBGYN unless you get a referral. Okay, so again, depending on your insurance, Susan. So it might just start with you giving your PT a call and saying, hey, I think I need to be screened by a pelvic floor PT. Who do you recommend? And if not, Google someone, and then either your primary care, if that's the way your insurance works, then you go to your primary care and ask them for a script. Let's see. Jill from Berkeley coming in later with hot tea. Thank you for joining us, Jill. All right, let's see what we got. Hey there, Keith. David says, Cosi, you're the first I've heard to mention this. Believe me, it's a real issue that needs more addressing, inclusive of all the nerves that kind of run through that area. Yes. And David, not going to lie, this is where my expertise went out the door. But again, I know just enough to get myself into trouble. I know enough to know that this is not something that's spoken of enough. And it's something that many people just accept as, oh, well, this is just part of the aging process. Oh, well, I have an enlarged prostate, so I'm going to have to run into these issues and just live with them. Or, well, I've had a lot of kids and I'm getting older in age, so this is going to be what happens. And it's like, no. I've seen some amazing improvements in some of my patients who had really severe cases and very severe symptoms. And, some patients that they weren't even able to leave their homes because of issues with their pelvic floor. And their lives got turned around by seeing a pelvic floor specialist and having these issues addressed. So yeah, I probably should talk about this more on the show. So if y'all want to elbow me in the ribs every once in a while and throw me a question about this, happy to do it. No, David, I don't mind at all. He says, I don't mean to be so abrupt, but I know a lot of men here were in the dark. Absolutely. And that's kind of a good thing about this live show is if somebody's embarrassed to ask these questions, or if someone's embarrassed to admit that they have some of these symptoms, they're in the privacy of their own home right now. So hopefully they can read this information and again, seek out the resources that they may need. So, and Keith says there are exercises to help with the weak pelvic floor as per my urologist and PT. Yes. And I know there's going to be somebody out there who's going to say, well, what about the Kegel exercises, right? We all hear about Kegel exercises. And, that's like saying, bicep curls are going to, help you, win a marathon. Kegel exercises are just like tiny little components of pelvic floor PT. We've learned so much more since the 1970s or whenever the Kegel exercises came about. And we've learned that there's more complexity there. As Pastor David mentioned, there's muscles, there's nerves running through that area. There's ligaments, there's tendons, right? A lot of stuff going on down there, right? So it's so much more than just Kegel exercises, so much more. And yes, I still run into doctors who will tell women, just do some Kegels and you'll be fine. It's like, no. Hey there, Pat. Pat, thank you so much for your kind email the other day. I was so excited to hear from you. So thank you. All right, guys, let's move along. Let's talk a little bit about, Julie had a good one for me. She says, I may have a topic for you. Really long hikes, trash, my lower back. And honestly, right now, low back pain is the biggest impediment. The morning after is pretty debilitating, and I welcome pointers. So many possibilities: hip tightness, core strength, Absolutely, Julie. You're hitting upon some of the big ones right there. Okay. So, last time I checked research, and I probably should check it again because it's been a while. I think it's something as much as 80% of amputees experience new onset of low back pain 5 years into their amputation. And I know probably those numbers are a whole lot higher, right? Very few amputees that I run into that say that they don't have back pain, right? So what are some of the causes? We go over this in the show, but I always like to repeat it for the newcomers. When it comes to low back pain, guys, okay, that's your body telling you that something is off kilter, right? So we talked about a few minutes ago about the core, right? You have your abdominal, back extensors, the diaphragm muscle, and now the pelvic floor. Now you know about the pelvic floor. So when someone is having low back pain, one of the things your physical therapist will screen you for is core weakness. And we examine all 4 parts of the core, right? Or we will screen for them at least, right? What are some other things that can be contributing to low back pain? Okay, so in PT school, they used to tell us, check the joint above, check the joint below. So the joints above your low back would be your upper back and possibly even your cervical spine. So we kind of look all up and down the spine. We just see what's going on. Is there a scoliosis going on? Is there a lordosis? Is there a kyphosis? Any unusual curves or flattening of curves in the spine? So we're taking a look at all this kind of stuff going on, right? Looking for muscle imbalances in the core. The joint below your low back would be your hips, okay? What's going on there? Do you have hip tightness, right? A lot of these muscles, especially the psoas muscle, let's talk a little bit about the iliopsoas muscle. It's a big old juicy muscle, right? And let's see, poor Bob. He's just getting, look towards the camera, Bob. All right, so your iliopsoas muscle connects right here on the inner part of your pelvic bone, right? But it also has connections to your spine. So if it gets tight, it's going to pull your spine into an increase, what we call increased lordosis, right? So kind of, if you see somebody with an increased lordosis, your lower back has a nice little curve, gentle curve. Somebody who has an increased lordosis means they've got a really pronounced curve. And sometimes we call it looking like they have a duck butt because their butt will kind of stick out a little bit more like a duck's, right? So an increased lordosis. I know we have great phrases in PT world. Right. So we look at the iliopsoas muscle. Is there tightness there? And that's a big one for my amputees, even my below the knee amputees, right? I always screen my below the knee amputees for hip flexor tightness, and inevitably most of them have it, right? So we're taking a look at this, right? So we're looking for weakness. We're looking for skeletal alignment in the spine. We're looking for hip flexor tightness, okay? We're also, and for me, I always like to travel down the line. I look for and I screen for weakness in the glutes. Weakness in the hamstrings, weakness in the quadriceps, right? The fact that you are missing lower leg muscles, it means that the muscles that are remaining are having to pick up more of the slack. So if they're not doing their job, well, then the stress and the tensions of walking and hiking are going to go up the chain, right? So we look at all of that. Someone who's a hiker, obviously they have to be much stronger. But even someone who comes in and says, well, just even in my walking day, just my regular day of walking, I'm experiencing low back pain. I take a look at their gait pattern. 9 times out of 10, guys, I can find something going on with their gait pattern that is contributing to the low back pain. And I try to address that first. Okay. And again, it can be the same. A lot of these problems can overlap, right? If you have weak glutes, okay, you're going to throw things off kilter and your lower back might take a hit for it, right? So lots of stuff that can be going on. Eric says, my back pain started a year out after amputation. I am getting a stimulator to help my back and phantom pain. Now, I'm all for like some of these modalities, right? We have modalities in physical therapy like E-stem or the TENS unit. We have dry needling. We have hot packs, cold packs. We have all sorts of fun toys to play with to help with pain relief. But ultimately, guys, it's not going to solve the root of your problem, okay? I happen to be a big fan of dry needling, okay? Had it done myself. But while it relieves the stress of the muscles, if you're not addressing the underlying weakness, right? Same problem is going to keep coming up over and over again. Yeah. So if you swear by your TENS unit, wonderful, but try to find out what is the underlying cause of your back pain and treating that, and you're going to find better results and longer lasting results as well. Got it, Eric? Watching you. All right. So Mark S says, I have spinal cord compression and stenosis. And again, when it comes to, well, spinal cord compression, Mark, that's something that, okay. I'm really hoping you're being followed by a neurologist for that one, depending on the degree of the compression, the cord compression itself. Okay, but let's talk a little bit about stenosis. Mark, you and I are going to follow up on that. With regards to stenosis, so it's just the narrowing of the vertebral canal, right? So you have your backbones. Come here, Bob. Right? You've got all your vertebrae, all these backbones, right? And then there's a little canal, and that's where your spinal cord goes through. And it's a very narrow canal, not a very wide canal, right? So with aging process and sometimes with injury and disease, sometimes that canal starts to kind of close in. There's calcification going on, and that canal starts to get a little more narrow, right? And the person starts to go, ow, right? You start having the back pain. You might have neck pain. You might have mid-thoracic pain. Okay, and the doctor will tell you you have stenosis, okay? And again, this is a part management part, okay? How do we manage this conservatively to hopefully avoid surgery or to prolong, the process before having to go into surgery to relieve the pressure from the stenosis or compression? So again, it goes back to the similar rhetoric from before, strengthen the muscles that are weak. Help with tightness if there is any. The stronger your muscles are around these structures, the more support these structures will have. Now, someone who has advanced stenosis, they're going to be having a lot of pain. Physical therapy will not take away all that pain. It won't. Okay. But keeping everything strong is going to allow that person to stay mobile and not lose their functional mobility, and will help hopefully in the long run. And then certainly for somebody who's had back surgery, either a decompression and a fusion, they need to follow up with the therapy to get everything strong around that to support the area that had surgery and hopefully to prevent further surgeries down the line. Yeah. Haha. Thank you, Brian. Okay. Page 2. I love it when I have 2 pages. It's awesome. All right. This one's from Diana, and I do apologize, Diana. I was not able to get this question on last week's show, so I saw it today and I said, ugh. And that happens, guys. If I do miss your question, don't feel bad about poking me in the ribs and say, hey, Cosi, you forgot to do my question. Won't take it personally, trust me. So Diana says, I'm so excited for the August 31st show. My amputation was from cancer. Earlier this month, I reached a big milestone. I got the news, 5 years cancer-free. So congratulations, Diana. That's wonderful. And she says, I know you understand the excitement as a fellow cancer survivor. Yes, I do. Question. I've experienced phantom pain on and off, but not consistent. It's been bearable. However, over the last couple of months, I have what I call nerve pain in the limb, but it's on the actual limb, not in the phantom part that's missing. And that's a very important distinction that she made. When I take the leg off, I massage the limb and it feels like needles, nerve sensation. I wear the shrinker at night and it hurts when I first put it on. Have you heard others express the same issue? We have tried a different liner thinking that may help, but no go. Okay. So guys, this is definitely something you've heard me talk about on the show a lot. The difference between phantom limb pain, phantom limb sensation, and residual limb pain, right? Phantom sensation, you can feel your toes where they used to be, but there's no pain. You can feel wiggling of the toes kind of thing. Phantom pain, it's exactly that. You're feeling pain where your foot used to be, right? And many of you have had all sorts of adjectives to describe this pain: burning, crushing, stabbing, squeezing, all sorts of terrible pain, right? Then there's pain in the residual limb itself. And guys, those of you who are watching this for the first time going, whoa, that's a lot of information. I have all of this on videos in my YouTube channel. Yeah, so you can go to my YouTube channel and I've got videos explaining all this. Residual limb pain is pain that occurs in the limb that is still there, in the residual limb, in the stump, in the little leg, whatever it is that you call it, right? So Diana, making that distinction is step one, okay? Because for me, I'm all about let's find out what the root cause is, right? We're not just going to throw treatments at you and like spaghetti at the wall to see what sticks, right? So the fact that she's having residual limb pain She's talking about it being like nerve pain. So she's talking about pins and needles sensation, right? This is indicative of maybe there's a neuroma brewing, okay? Or there is something bothering the nerve, okay? So it could be a neuroma. It could be that there's just some scar tissue in the residual limb that's not necessarily a neuroma, but it's just in the area of that nerve, right? It could be that there's something else, maybe even a bony spur, and it's pushing up on the nerve. Okay. Whatever it is, there's a nerve there that's hot and bothered. Okay. So, first of all, figuring out what is it that's going on, right? Then you can try to figure out what is aggravating it. That's the other side of it. So it sounds like when she's wearing compression, that's when she's feeling it most. And I never forget what my buddy Greg Menino, he's an amazing prosthetist. You guys have seen him on my show several times. He and I did a lot of shows with Vital Fit, the skincare company. Wonderful prosthetist. And he's an above the knee amputee himself for over 3 decades, right? And he says whenever his patients come in, a lot of times they're wearing a socket that's too tight. And that always stuck in my brain because he says that. He talks about that. And he says a lot of times people are complaining about pain in their residual limb and it's shooting off nerve pain. It's shooting off phantom pain. And it's because their liner or their socket or both are simply too tight. Right? So it sounds like master of the obvious. And it's like, well, that has to be tight because in order for it to stay on, it has to have a snug fit, right? But there's also just too tight. Okay. Now it's interesting that when you take your leg off, Diana, and you didn't include this in the comments, so I'd be curious, when you take your leg off, do you find that things resolve, right? Do the symptoms resolve? Okay. So these are just different things to think about, Diana, but I think you're on the right track in saying, okay, there's a nerve in there that's being bothered. We need to figure out why. Okay. And then go from there with the treatment. What is it that's exactly seeing a surgeon that can really truly screen you to see if you have a neuroma sitting in that area. Okay. All right, Eric, I will take a look at that. I love looking at MRIs. So yay. Susan says, I had those dang burning fiery pins and needles. I do not have any, zero since having the TMR operation. And again, guys, as much as I love targeted muscle reinnervation, love that procedure, it's meant to address neuromas. So if your pain is not being caused by a neuroma, TMR is not going to help. So I'm putting that disclaimer out there, right? So for me, that's why it's like, let's figure out what's going on. So Diana, I'm going to encourage you. That website right there, Diana, tmrnerve.com. If you go to their physician directory, and I love this feature, by state, they list all the surgeons that perform targeted muscle reinnervation. My suggestion to you would be, Diana, if this is continuing to be a problem, make an appointment with a surgeon that does TMR. Why? Because they're going to know how to screen for a neuroma. Makes sense, right? They're going to be the ones to be able to tell you for sure, do you have a neuroma or not? And then you can go from there. Does that make sense? So that's just my 2-cent advice there for that. So Felicia says, I was told nerve damage. And yes, that's still very much a possibility, Felicia. Yes. And last week on the show, and again, Felicia, I don't know about your particular case, but last week on the show, Dr. Ribot pointed out that patients who have some flavor, there's so many different osteosarcomas out there, so many different kinds, right? But many of them have to undergo chemotherapy. And chemotherapy, it's neurotoxic, meaning it's toxic to your nerves and can cause nerve damage. Okay, a lot of chemotherapy patients who have had a lot of chemo experience the neuropathies, so the pins and needles sensation, right? So it goes to say that if you happen to be a cancer patient that you've been receiving chemotherapy, that is one form of nerve damage that can be present also in the residual limb, right? So Felicia, I'd be curious to understand, to ask, and just to kind of dig a little bit more and say, well, what do you mean, the person who told you had nerve damage, to ask them, what do you mean by nerve damage? Can you explain that, please? Is it because you have nerve damage in the fact that the nerve is cut? and they call that nerve damage. Do they mean that there's a neuroma? Do they mean that the nerve is no longer transmitting? So I'd be curious to see, what they mean by nerve damage. And then how is it affecting you, Felicia? There's some people that they know they have a neuroma. For example, one of my buddies that I go running with, he knows he has a neuroma. He knows he has a neuroma, but thankfully his prosthetist is a rock star and was able to make a socket for him where he does not feel the neuroma when he's walking or even when he's running. Thank goodness, right? That he only knows that the neuroma is there is when he taps on it and then he feels it, right? So there are some people that have neuromas, may not even know it, okay? So just again, guys, a lot of this information, let me just remind you about the show. The purpose of the show is for you to just gain information so you have just more awareness, right? And then also having this ability to have this communication with your clinicians, because ultimately they're the ones who know you the best or know your case the best, more than I do, right? So just to have this communication tools available to you. All right. Okay, so Diana says, no, it still hurts when I take the leg off and even in the morning. Thanks for the info. Diana, again, I would just encourage you, look on that website. Look to see if there's someone in your area that can just screen you for this. Okay, because yeah, that sounds very painful, and nerve pain is on the top 5 of most painful pains the human body can experience. So if it's not already impeding your use of the prosthesis, it may start to. And I would hate to see you lose mobility because of pain, right? Okay. Oh, my pleasure, Susan. Thank you. All right. Ooh, last question, but this is a good question, guys. Guys, can I put in a shameless plug for a minute? So I'm going to do this right now. Those of you who are already in the Cool Kids Club, you're good to go. So last November, it's actually going to be a year, guys. It's almost been a year. I launched the Cosi Talk Strong Body program. And it is basically 150 exercises that I videoed with beautiful amputee models for above the knee and below the knee amputees. And I have exercises for arms, legs, and core strength, for balance, and for flexibility, and for all phases. So these are exercises that I have done with my patients from the minute they leave the OR up through my runners and my athletes. And there's something in there for everybody. So I have a lovely website that my team put together that I'm so proud of, and that's what I put up there right now. And there's an online subscription that you can have access to all of these exercises. And in the online subscription, because you guys know I like to talk, right? Y'all know I like to talk a lot. I have a lot of information on how to approach the strengthening process, how to approach a fitness program. So I have all of that education information in there. And I also have these 2 books, full color, and they have all of the exercises inside. Because I know some folks, like for me, I'm a visual learner, very visual. So I like to watch a video of an exercise, but I also like to see pictures and just read descriptions of the exercises. So I have all of that in here, and I also have all of the education in here as well to go. So I have one for above the knee and one for below the knee book. So guys, if you don't mind, after the show, show me some love, go visit my website, give it a go. And those of you who already have subscribed, I have so many subscribers and it keeps growing and the books keep selling. Many of you are taking these programs back to your prosthetist, back to your physical therapist. I do have packages that your prosthetist can purchase. Okay. And I have several prosthetists. You'll see there's a little directory there of the prosthetists that are participating in this program, and they are giving these subscriptions to their patients. So many of you have taken this program back to your prosthetists and PTs, and I thank you for doing that. All right, guys, let's get this question. This one says, this one comes from Hassan. He says, hello, I am a right leg above the knee amputee, currently using the Ottobock 3R80 as a knee joint here in Pakistan. I think this is my first viewer from Pakistan. Very cool. It's been 2 months now and I'm walking fine with a stick, but when I walk without a stick, my posture is very absurd. Can you please guide me? So yes, a lot of times when people, it all depends on, again, going way back to the foundational exercises. You know, did this person receive physical therapy? Did they receive therapy from a specialist that started them with these foundational exercises? A lot of times when I have a patient who's using a cane and they're transitioning from using a cane to walking independently, right? The first few tries, there's going to be some postural deviations or a limp, as people will call it, right? Because it's just a new sensation, right? So usually when this happens, I don't jump to conclusions right away. Usually I just say, okay, let me let the person practice walking without the cane, and let's just give them a few laps here to see if their brain figures it out. And hopefully the training we've been doing prior is going to kick in. Okay. So if I notice that a person has a postural deviation, that they're leaning too much to one side, that they're leaning too far forward, they're leaning too far back. Okay. Then I start asking myself questions. It's like, okay, what am I missing here? Do we need to go back and do some balancing exercises? Do we need to work on their proprioception? A lot of times when you have postural issues, it's because you don't trust your body's sense of proprioception. So the person might freeze up. Okay. Do we need to try some strategies where we go back to the parallel bars and go back and do some of the foundational exercises without the cane? Right? A lot of times when we start these foundational exercises, we'll do it holding onto two hands with the parallel bars, but we can sometimes go back and then try them without using the cane and do those foundational exercises again. Okay. So there's a lot of ways, guys. Again, this is where good solid PT can really do wonders for helping you really maximize your mobility, whether it means being independent with a cane or without a cane or with a walker. Okay. A lot of stuff there. So Hassan, I sent him an email and I asked him a few more questions, follow-up questions, and hopefully, I don't know if he's going to be able to watch with the time difference live, but hopefully he'll be able to watch, and we're going to hopefully continue that communication there. All right, guys, I think that's it for this evening. I do want to make an announcement. Next week, we're having Ronnie Dixon of Prosthetic and Orthotic Associates of Tennessee. He is coming on board, and next week's going to be a real fun show, guys. Ronnie was the world champion, number 2 in the world for rock climbing. Yeah. Kind of a badass. He's really cool. So he's going to be coming on the show. He's an above the knee amputee, and he's also an amazing prosthetist himself. He's been on the show several times this year, bringing in his knowledge. So he's going to tell us a little bit about his story, and he's also going to talk to us about rock climbing, adaptive rock climbing, and adaptive sports. And I've done several shows on adaptive sports, and that's something that I really, really encourage. Even if you never did sports before your amputation, right? Why not give it a try now? If you guys are on my email subscription, I sent out a really cool email about that. So go check your emails, okay? So guys, come next week. We're going to have giveaways. We're going to have a good time. 8:30 p.m. Eastern Standard Time on the Cosi Talks Facebook page and YouTube channel. Same bat time, same bat channel, guys. All right. As always, thank you for letting me be a part of your lives this evening, and I will see you guys next week. God bless.